represents a different flavor of applications. He will be talking about tumor-targeted fluorescence for guided surgery. So this is very important because that allows to make surgery more effectively and monitor the margins of the tumor. And again, it introduces you to different facets of applications here. So with no further ado.
Thank you. Let me begin by thanking Peter for the invitation to speak here. And I don't know how to switch over to my slides. Okay, good. So I would like to speak about tumor-targeted fluorescent dyes for fluorescence-guided surgery. And I should mention at the outset that much of this work was supported by a couple of companies that I've started, OnTarget and Endocyte, and it's been the work that I present is largely done at Purdue University. We have been developing a number of different applications of a very fundamental technology where we use a low molecular weight targeting ligand linked via a spacer to a payload. And the payload that we've been delivering for most of the effort that we've been conducting in my lab has been either a therapeutic agent or a radioimaging agent. But for the purpose of the seminar today, I'm going to focus specifically on the use of this same strategy to deliver a fluorescent dye specifically to cancer cells for the purpose of illuminating these cancer cells and guiding the surgeon's knife and showing him where the malignant disease is. And I won't, since this is a cancer symposium, I'm just going to talk about targeting ligands that target cancer cells. But we have a number that we'll be publishing shortly that target inflammation, infectious diseases, and even some CNS diseases, some targeting ligands that are very specific for those. So the same principles apply, but they aren't directly related to cancer. I'm going to talk about 4 different targeting ligands in this seminar. The first one is folic acid. Folate is required for the synthesis of nucleotide bases, and so rapidly dividing cells that have to make a lot of DNA have an enormous appetite for the vitamin folic acid. And there are 3 routes by which this vitamin is taken into cells. One is the reduced folate carrier, a second is the proton-coupled folate transporter. They both have relatively low affinity for the vitamin folic acid. Moreover, if you link a drug to folic acid, neither one of them will transport the conjugate, the folate-linked drug. There is a receptor that's overexpressed on a few cells, including cancer cells and inflammatory macrophages, that has a much higher affinity for the vitamin, about 10 to the minus 10th molar. And fortuitously, if you link a drug or an imaging agent to folic acid at one end of the molecule, it still binds with very high affinity, very similar affinity to the other end of the molecule, to the folate receptor. This then enters the cell by receptor-mediated endocytosis. This is a cartoon of the process. The vitamin is actually yellow in color. Folic acid is yellow. It binds to a GPI-anchored protein, glycosyl phosphatidylinositol-anchored protein on the cell surface and enters via endocytosis. The imaging or agent or drug is then released inside the cell. Where are folate receptors expressed and accessible to folate conjugates? We find them overexpressed on a large number of cancers. Roughly 40% of human cancers overexpress a folate receptor. Most ovarian cancers express a folate receptor. Non-small cell lung cancers, roughly 80% do. A good fraction of breast cancers, but it's especially highly expressed in triple-negative breast cancer, which are the most difficult to treat by classical methods. It's overexpressed in a good fraction of kidney cancers, a few brain cancers, about a third of colon cancers, and then the myelogenous leukemias like AML and CML overexpress it. But interestingly enough, the folate receptor is also overexpressed on activated macrophages and activated monocytes, but not on their resting counterparts. And recently we have found that a subset of these cells that migrate into tumor tissues. They're called myeloid-derived suppressor cells, and they turn off the immune system in tumor tissue and induce angiogenesis and release growth factors. These express macrophages. These express folate receptors also. They're very rich in them, and they make a very good target for cancer therapies. The proximal tubules of the kidney also express high levels of the receptor, and they're accessible to any folate conjugate that filters into the urine. This is cumulative data on folate receptor expression in different cancers: ovarian cancer, small cell lung cancer, kidney, endometrial, and colorectal, and breast. These all seem to express fairly high levels of the receptor. Then there are other cancers that express very low levels, and it's these cancers here that really cannot be targeted with a folate-linked imaging or therapeutic agent. So we have to go up after other targeting ligands that will be directed towards other receptors in order to treat these cancers. But because a good fraction of these major cancers can in fact be targeted with folate-linked drugs, we are relying heavily on folate for imaging and therapy of these cancers. One important characteristic of the folate receptor expressing cancers is that in general, the level of folate receptor expression is inversely related to survival. These are some data that we obtained in collaboration with a group from Mayo Clinic under Lynn Hartman, comparing cancers that expressed low levels of folate receptor and those that expressed high levels of folate receptor. This is specifically breast cancer, and these are Kaplan-Meier curves, and you can see that those that express low levels of folate receptor have a better prognosis. And so, specifically those cancers in general that are hard to treat are those that we can in fact target with folate-linked drugs. This same trend is seen with ovarian cancer, with colon cancer, and several others that we've looked at. Early on, whenever we prepare a new targeting ligand, we hold our breath. I was talking with Marty Pomper just before this session, and telling him that we really don't know before we inject these into humans where they're going to go. We have a lot of information that we obtain from our animal studies, but until we really test them in real people with real cancer, we have no strong evidence that the strategy will work in delivering imaging and therapeutic agents to these cancers. So this was the very first patient we imaged. It was a healthy volunteer. This was with folate linked to DTPA with an indium-111 on it, and we saw the kidneys. Now, if you remember at the beginning, I told you that folate receptors are overexpressed and accessible in 3 different tissues. There are a number of cancers, activated macrophages at sites of inflammation, basically, and then the kidneys, if it can filter into the urine. And that's what you're seeing here. And this is a patient with a stage 3 ovarian cancer, and you can see the distribution to the malignant tissue. If the patient had had, an inflammatory disease like rheumatoid arthritis, Crohn's disease, ulcerative colitis, atherosclerosis, any of these inflammatory diseases, you would have seen it also at the site of inflammation. Here's a patient with a breast cancer metastasized to the brain. This is a primary brain cancer. This is a kidney cancer metastasized to the backbone. You can see these also. I'm not going to spend any time on this, but I just mentioned that because I know there are many people here interested in cancer and not so much in surgery, that we've also developed folate-targeted therapeutic agents. There are 6 now in clinical trials. And this one, which was purchased by Merck a couple of years ago, is now in phase 3 and several with other cancers in late phase 2. These are data on its use in combination with Doxil versus Doxil alone, and this is Doxil alone down here, its effect on progression-free survival of ovarian cancer patients. And these are data after treating 150 patients in a blinded randomized trial of platinum-resistant ovarian cancer patients. And the importance of the imaging agent is that if we select for patients using the folate-targeted imaging agent, if we can to see if we can see the tumor, and only treat those where we see all of the tumor tissue, then we see a 263% improvement in progression-free survival. If we don't select for patients and just take everyone that comes without using the imaging agent, without making the medicine personalized for the particular patient with the cancer, we see only an 85% improvement. But even that's better than the 3 approved drugs for platinum-resistant ovarian cancer. If a drug is truly targeted, then one would expect that there would be less toxicity to healthy tissues if it really is targeted to malignant tissues. And these are data from a phase 2 trial where we didn't combine it with Doxil, but just it was used by itself. And we're looking here at the grade 4 toxicities after the first 100 patients were analyzed. And you can see there were no grade 4 toxicities, only minor grade 3 toxicities, most related to constipation, which was easily resolved by an over-the-counter laxative. In addition, unlike most cancer therapeutics, we have, as far as I know, never seen any suppression in white cell counts. In other words, the bone marrow has never been knocked down by these folate-targeted drugs, and the main reason is there are just no bone marrow cells that have folate receptors. The free drug, on the other hand, or something related to it, this is not the drug that we're targeting in this case, gave 43% of the patients saw a significant suppression in bone marrow. Now on to intraoperative imaging. I had a graduate student named Mike Kennedy back around the turn of the century. It shows you how old I am and how long we've been working at this, who developed folate-targeted fluorescein dyes. And in this particular animal model, you can see the heart there and the lungs. We could see the metastatic disease in this metastatic tumor model. It's a metastatic lung cancer model. And this encouraged us, and we actually, a number of years later, got in contact with Dr. Go Van Dam at, I don't know how to turn off the sound here, in the University of Groningen. And he injected a ovarian cancer patient with the folate linked to fluorescein very shortly before surgery, like an hour before surgery, and then after removing all the malignant disease that he could see with the naked eye and by palpation, by usual surgical techniques, he then turned on the fluorescent lamp to see what he had missed. If you turn down the lights for a second, I don't know whether you can do that or not, you'll see this a little better here. Now these are the, he's done with the surgery. He thinks he's resected all of the cancer tissue, and then at this point you can see it's very difficult to distinguish anything malignant from normal tissue. Then he turns on the fluorescent lamp, and that's up in this corner here, and he sees lots of fluorescent tissue. And he moves in and resects this, and you can see at the same time the malignant lesion there that he sets off to the side, and because he doesn't know whether this is cancer tissue or normal tissue, the pathologist grabs it with her forceps and runs it off to the pathologist to ask the question. Here's another piece being cut off, and he sets it off to the side. Now, the camera here is an excellent camera. It was built by Vasilis Tsiakristos from Munich. And he enabled the overlay of the white light and the fluorescent images on top of each other in a subsequent patient. You can see the malignant lesions here in the bright fluorescence here. It's not a surprise that these malignant lesions might have been missed by the surgeon because they're only the size of the tip of these small forceps, maybe a millimeter or so. And because in the absence of fluorescence, they just look like normal tissue, it's very difficult to identify these. But with the aid of the fluorescence, it turns out, as was published by Go Van Dam in Nature Medicine, he was able to remove 5 times more malignant lesions with the aid of fluorescence than beforehand. Moreover, all of the fluorescent masses that were removed were confirmed by pathology to be malignant tissue, so there weren't any false positives. Because there's a lot of data now to demonstrate that more complete tumor resection in ovarian cancer has a very strong impact on survival, improves survival significantly. We believe that this strategy has a significant chance of improving patient survival, at least in this disease. Subsequently, we have introduced the folate fluorescein into several other hospitals. These are data by Dr. Sunil Singhal at the University of Pennsylvania. This lesion here was seen in the CT scan. This one was not. And upon opening it up, it was, resecting it, this was confirmed to be malignant. Others at Penn are also doing it. At Mayo Clinic, there are others, surgeons also working on this. Let me just jump ahead a moment, though, and it comes from this demonstration here. If you see this fluorescent light right here, if I put my finger over it, you can't see any fluorescence through my finger. I'm sure all of you are familiar with this. This is a much dimmer red light, but when I put my finger over it, you can see the fluorescence very clearly. This demonstrates that red light penetrates tissue much more efficiently than green light, and so because of this, we did some studies where we took the folate fluorescein, which is green, and injected it into the tail vein and looked to see what we could see in a folate receptor expressing mouse. And the same tumor in another mouse, thank you, was then imaged with a folate linked to a near-infrared dye where the light can penetrate the tissue. And the difference, here are the structures down here in case you're interested. The difference is extraordinary. This is very easy to see and this is not. So this indicated that we should switch to a near-infrared dye. And we went through a whole series of them, looking at them under about a 1 millimeter thick section of pork meat, just to see which ones at their own optimal wavelengths would transmit best. It seemed like a simple experiment to perform. And we found that actually, not surprisingly, the further we went towards the near-infrared, the better off we were. We linked a number of these up to folate, and this is the one we ended up deciding to move forward with. As for obvious reasons, it was very bright. It targeted tumor tissue very specifically. There were others that worked well. Some of these are actually underrepresented because the excitation wavelength is not ideal for the dye. But nevertheless, and after looking at a number of different parameters, including stability, including intensity, quantum yield, extinction coefficient, the absence of byproducts in synthesis, the ease of synthesis, and so forth, we ended up with that conjugate. We call it OTL38, and it has a binding affinity identical to that of free folic acid, so it's roughly in the neighborhood of 10 to the minus 10th molar. It targets very nicely folate receptor positive tumors. It does not target folate receptor negative tumors. And the only place where we see significant uptake is in the tumor and in the kidneys. And again, this is a site of excretion. Moreover, we can go down to as low as 1 nanomole per mouse, even actually a lot lower than this. We can go into the picomolar range per mouse and inject virtually very little material and still see very bright fluorescence uptake in the tumor. These are the kidneys, the site of excretion, that are showing through here, so you also see uptake there. And folate receptor negative tumors show no uptake. One of the interesting consequences of some of our studies in this area was to find that another form of the folate receptor called folate receptor beta is overexpressed on activated macrophages and other myeloid cells that are activated or in an inflammatory or anti-inflammatory state. And this is just a stain of a section of human liver cancer stained with an antibody to folate receptor alpha and folate receptor beta. And the bar graph that I showed you at the beginning of this presentation contained only the data on folate receptor alpha expression. Subsequently, we've gone back, and I don't have time to show this to you, and we've stained lots of tissue microarrays for folate receptor beta. Different cancers, and there are a lot of cancers that express little or no alpha that now express very high levels of beta, and so that initial bar graph that I showed you is an underrepresentation of the folate receptor positive tumors that we can target. And so we decided to look at a tumor in an animal model. We haven't conducted these studies in humans yet, that we know is totally folate receptor negative, and this is a head and neck cancer. And this is a folate receptor positive tumor, but even though the cancer cells do not express the folate receptor, the infiltrating tumor-associated macrophages do express it. And even though they're fewer in number than the cancer cells, it's still possible to image many of these folate receptor negative cancers because of the influx of these folate receptor positive macrophages. And we think that this is also important for therapy because they, as I mentioned earlier, are very important for the survival of the tumor. Now, after experiencing what we felt was good success with the use of folate to target cancers, we decided to undertake to find new targeting ligands that might help us to address the need to target drugs to those tumors that don't express high levels of folate receptors. And one of those was prostate cancer. And the American Cancer Society estimates there are about 220,000 new prostate cancer cases in the U.S. each year. And a receptor called prostate-specific membrane antigen, which we've used a molecule called DUPA that it's just an acronym for the chemical name, that binds with very high affinity. Marty Pomper here in the audience has, concurrently developed a very similar molecule for targeting prostate cancers. And we have, in addition to using this urea-like compound, we've used the crystal structure of PSMA to build a spacer because the ligand binds so deep in this pocket, we fit some of the spacer to other side pockets in this tunnel here to improve the affinity. And that's these phenylalanines, it turns out, fit into side pockets in that tunnel. And we ended up with a high affinity imaging agent with a technetium here, a chelating agent with a technetium on the end that binds with about 14 nanomolar affinity. When we compete it off, we get nearly quantitative competition. And this is just an image of a patient that we scanned with the DUPA, our PSMA-targeted imaging agent, compared with the same patient that was targeted with a bone scan, and this bone scan binds to naked hydroxyapatite, and prostate cancer frequently metastasizes to the bone and eats down through till you have just the naked bone exposed. And you can see this lesion here is that one right there, and this lesion in the shoulder here is that one up there. This one here is over in there. But what this cannot reveal is a malignant disease that hasn't eaten through to the bone yet. And just to make a long story short, we've sampled lesions not imaged by this and found that are imaged over here, and found that they are in fact also containing malignant tissue disease. So we developed this into we've made a PSMA-targeted near-infrared dye. The data are shown here. We use a 22RV1 tumor model, see very good uptake in the tumor. In contrast to the folate-targeted agents, it doesn't really accumulate to significant amounts in anywhere else except for some parotid glands in the neck. PSMA-negative mice don't show uptake. We've also performed some surgeries. You can see it through the chest with the near-infrared dye. You open it up and you see it. This is a dye that has probably been excreted and has somehow got on the skin there, and when you fold back the skin, you see it fold over to the side. Just very quickly, we've developed targeting ligands for other receptors. The cholecystokinin 2 receptors overexpressed on small cell lung cancer, pancreatic, liver, some colon cancers, gastrointestinal stromal tumors. And this is the structure of our targeting ligand. We've linked it to the same near-infrared dye. We have very good binding affinity, and we get very good specificity. Again, if you look at the internal organs, it's really tumor-specific. Here's just an example of a whole animal, and then when you open it up, you see the malignant tissue corresponding to what you saw in the whole animal. We can compete it off. with an excess, and it's like the other. Another one that we're going after is very heavily overexpressed in glioblastoma, glioma, retinoblastoma, and so forth, and a few other sites where there are neuroendocrine tumors. And it also has very good specificity, and the competition can knock it down also. We're in the process, I don't have time to show you it, we have data on a number of these targeting ligands for a number of other cancers of the skin, brain, liver, B cells, and stomach, and so forth. And we hope to be able to develop all of these into tumor-targeted fluorescent dyes to be able to make a cocktail. And the purpose, this slide here simply shows that when one puts, for example, CCK2 positive cancer cells in the dish, and folate receptor positive cancers in the same dish, you don't see both of them with one targeted fluorescent dye, but when you form a cocktail of the two, you see all of the cells in the dish, and we think that's principle. It's pretty obvious that it should be, with a good cocktail, we should be able to image most tumors. We're also developing some targeting agents so the surgeon can see the nerves and distinguish them and blood vessels. In the case of prostate cancer, for example, if the nerve is severed, then there are problems with incontinence and other issues. And we've developed a number of different new near-infrared dyes that are shown here, and all the way out to excitation at 873 nanometers, so that we can use near-infrared dyes of different colors for different to help normal and diseased tissues. I don't know what my time is. 2 or 3 minutes. We started about 5 minutes late, if you remember. Yeah. So anyway, we're also looking at ways to count circulating tumor cells in the bloodstream, and we can inject these tumor-targeted fluorescent dyes, and you can see actually just using a microscope, a multiphoton microscope up on the blood vessel, one can see them in circulation. I'm going to just conclude with one concept. We don't use antibodies because of the time required for the antibody to accumulate in the tumor. And we have a very good demonstration of this, and this is seen in this particular movie where we focus in on a blood vessel and just look at the rate of accumulation of a folate linked via PEG molecule to rhodamine. So you've got a folate, PEG, and a rhodamine. You can just follow and quantitate the kinetics of accumulation here. And if we just show some still shots of a different blood vessel using where we've injected in the tail vein of a mouse folate PEG 5000 rhodamine, you can see that very little accumulates by 65 minutes, where we have a PEG 5000, a 5,000 molecular weight PEG in between folate and rhodamine. If we then, in the same mouse, you can see this is exactly the same blood vessel here. We inject in the tail vein at 66-minute time point, or the 65-minute time point, folate rhodamine without a PEG in there, so it's just smaller, same folate, same rhodamine, one of each in both cases. We can see within 5 minutes the tumor saturates here. And that's just an impact of size in terms of tumor penetration. And because the surgeons all want to inject and here's the kinetics of that. This is the folate PEG rhodamine, and this is folate rhodamine, and within 5 minutes you get tumor saturation. Because the surgeons want to be able to inject the patient while they're prepping them for surgery, rather than have them come in a day or two early and then come back again, we think this is an important consideration. And finally, we're also developing some folate-targeted photodynamic or other ligand-targeted photodynamic therapeutic agents, where we use a photodynamic therapeutic dye at one end that causes release of reactive oxygen if you shine light on it. And because we can target those dyes very selectively to the tumor tissue, and so they avoid uptake in the normal tissue, this should make the photodynamic therapy very safe. These are my conclusions. Ligand-targeted dyes can reveal malignant disease that can't be detected by the naked eye. We've seen that already by Go Van Dam and Groningen. Targeted dyes will soon be available for all major cancers and inflammatory diseases. Marty Pomper's making some of these. We're making some. Others are making some. So I think it's going to happen. Low molecular weight targeting ligands are superior to high molecular weight targeting ligands for fluorescence-guided surgery. Just the timing and so forth make them better. And I think they also accumulate in much larger quantities. Fluorescence-guided surgery should facilitate resection, elimination of positive margins, minimization of resection of healthy tissue. And when you're doing surgery on the brain or in the breast where the healthy tissue is wanted, eliminating the excess removal of healthy tissue is important. It's also important in tumor staging. And then I think the same targeting ligands can be exploited for a lot of applications. And then finally, we think that use of multicolors will further aid the surgeon during surgery. So thanks very much. And here are the people I need to acknowledge. Well, right now we're injecting 1 nanomole per mouse. Per mouse.
The slide that you showed for the
In humans, we're injecting, we haven't optimized the amount, but it's less than 1 milligram per person injected. We're hoping that it'll be down around 100 micrograms. They're pretty specific, so they home in very nicely. We design them, we want them, that's a good question, we want them to be excreted because any that hangs around is just going to create background fluorescence. And so we make the spacer very hydrophilic, and the PK data that we have so far on folate fluorescein suggests that it drops to about 2% in about, of its inject dose in about 20 to 30 minutes. So if it doesn't find a cancer cell, it's excreted, it's out of there. So within an hour, we have very good images.
there's no accumulation in any.
No, there's some, I mean, you saw with folate, there's uptake in the kidney. The kidney has a salvage receptor on the apical surface of proximal tubular cells. It captures folate from the urine and carries it back and dumps it into the bloodstream so that you don't become folate deficient. Otherwise, you'd lose all your folate in 10 or 15 minutes. And so but that doesn't seem to cause any problems. It doesn't keep it there for a long period of time. It's carried, it's a salvage pathway.
Some people are using nanoparticle-based imaging techniques for delineation of margins, and you are using the dye.
Right.
Any pros and cons comparisons?
Well, there are some very clever nanoparticles. Jinming Gao has a very nice pH-sensitive nanoparticle that has a very sharp pH dependence. Because the pH in the tumor tissue is often lower than elsewhere, it really lights up very nicely in a lot of different tumor types. I think the major disadvantage is the time. These have to be injected at least 24, in some cases 48 hours ahead of time to get good tumor contrast. And, but you know, for drug delivery, that's not an issue. You just as soon have the delivery spread out. So I think for therapeutic applications, that's okay. But for, you know, imaging applications, most imaging is done right at the time the patient comes in. They don't want to have to come in and then find out 2 days later. Yeah.
Any other questions, Todd?
Yeah.
So for the circulating tumor cell detections, how's the sensitivity compared to
Okay, the question is, what is the sensitivity of our quantitation of circulating tumor cells? We have a hard time evaluating that in vivo because we can inject, spike the blood with tumor cells, but how quickly they're filtered out by the liver and captured in the microvasculature in the animal is hard to say. I can tell you that we can ex vivo analyze them, spike a blood sample with a cancer cell, put in the folate-targeted fluorescent dye, and then run it on a flow cytometer. And when we do that, we can pick up over 90% of the cells. That's an excellent question, and we really don't have a lot of information on that in humans. In mice, it's a pretty easy thing because they're so small. It's easy to see where the fluorescence is coming from. A number of people are anticipating solving that problem by making a combination imaging agent with a PET agent and a near-infrared dye on the same targeting ligand. And the surgeon would then use PET imaging to see where the malignant lesions are distributed and then dig there with his surgical equipment to find till he got in where the fluorescence could take over on the localized level. Does that answer your question? I think you're right. There's a lot of scattering of light, and so, but many cases the malignant disease is superficially located, like you saw in the ovarian cancer. We've seen an awful lot of malignant disease in these lung cancer surgeries. I only showed you one image of those where that would not have been seen otherwise, and so I think it's still going to be extremely valuable.